and answer session following completion of the presentation. You can submit any questions you have throughout the presentation by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Our presenters will attempt to answer as many questions as they can during the time we have, and will follow up on questions they do not have the opportunity to address. You will receive an email following the webinar from marketing@medigain.com that will include instructions for how you can download a copy of the presentation. It's now my pleasure to introduce today's presenter, Liz Taylor. Ms. Taylor is currently the ASC Operations Manager for MediGain, a revenue cycle management company. She has been part of the ASC industry for more than 10 years, representing leaders in the industry such as ASCOA and USPI. Clint Hughes is VP of Marketing with MediGain, and he will be helping Liz moderate and answer questions today. It is now my pleasure to turn the floor over to Liz and Clint to begin today's presentation.
Thank you, Carrie, for the introduction. Good day, everyone, and thank you for joining me. Today we're going to be going over the 5 ways to increase the out-of-network revenue for your ambulatory surgery center. As we all know, there are more than 5 ways, but I plan to touch on the 5 here. Not any of us are experts. That's why we have to get together in webinars such as these so that we can share our information that we have gained, in our processes, our working at the ASCs. Today what we're going to go over is the importance of verification of benefits. I believe that a lot of people don't understand the importance of verification of benefits and do not do it as thorough as they should. So we're going to go over that and the best practices. What is the best way to collect from the patient up front? The insurance is paid. Is this all I get? Payment poster responsibilities and collector responsibilities. By going over these 5 items, it will help you understand the details that go with everybody's job functions and the importance. Next slide. So the revenue cycle management process, as we all know, begins at the time that the surgeon's office calls to schedule the surgery at your facility. You want to make sure that the surgeon is providing all the data, all the imperative data, such as the CPT codes. Are they going to need implants? You need to get that scheduled. It all begins there. So once your scheduler obtains that information, it is then their job to pass that information on to your clinical staff to have the necessary items there, or to contact the insurance company, know the cost of the case to make sure that it's going to be cost effective for your facility. Next slide. Okay.
Liz, we just had hi, this is Clint Hughes, people, and Liz, we just had a question. How long in advance? So within 24 hours, okay, so that question was a little premature. So for calling up and getting that, as you were referring to in the first slide, about 24 hours in advance, or a little more time is needed?
Yeah. So the standard process in most ASCs, is, as you know, is you will get a call or a fax from the surgeon's office stating, okay, I have my block time, this is what I want to do. So within 24 hours, it's best practice for you to have your verifier contact the insurance company and obtain the correct information. I'll go into more detail on exactly what needs to be done, but as you can see in this slide, I'm stating that the EOB needs to be done within 24 hours. They need to know how much does it cost to perform the case. This is important for your staff to know this so that they can make an informed decision on the front end prior to approving that case. Do you have the resources available for your insurance verifier? Are you maximizing their efficiency and having them utilize websites, trend tracking, something that I'll talk about later, so that they have all the data that they need to make, like I said, an informed decision? And are you collecting from the patient up front? Next slide. Okay. I think we went back. Okay, so
I think you went backward,
I think
go
we
forward.
Went back. I apologize, yeah. Honestly, I'm so passionate about ASC and the processes that need to take place that the slides may throw me off a little bit, just because.
One more.
Yeah, I apologize.
There we go. No?
Nope.
You're going backwards, not forward. There.
All righty. Okay. So in the ASC, whenever the patient is scheduled at the surgeon's office and the information is transferred to the facility, As I stated previously, you want to call and verify the benefits within 24 hours. If you're an out-of-network provider, there are certain questions that you need to ask to ensure that you're getting all the information needed to make a good decision on whether or not that procedure is going to be cost-effective for your facility. The things that you need to be thinking about is whenever I do verify those benefits and I get that information and I contact the patient to let them know what is going to be their responsibility, am I giving that patient options for payments? When you have flexibility in payment options, people are more likely to pay you the full amount. How many patients do you have that cancel due to being unable to perform their portion of the surgery? Make this assessment to decide if you need to take a second look at internal processes and policies. Next slide. So what I'm going to do, like I said, this can be confusing, so I'm going to go through my slides, and then I'm going to go into detail on each of the processes that take place within the ASC. I believe that's going to be more informative, and I'll be able to speak better to it. VOB is your process efficient. As you all know, you want to obtain in and out of network benefits. You want to confirm whether or not there are any daily maximums, ASC limitations that apply to the policy. You need to ask what methodology is used for determining the out-of-network allowable. Is a third-party network used for pricing? If yes, which one? Some examples are First Health and TRPN. Reasonable and customary, whenever the representative at the insurance carrier gives you that information, you want to ask what percentile of that. What is the insurance carrier's multiple procedure reduction? And that is important. I can explain why just a little bit later. Next slide. Okay, so here it is. The NPR is important because, as you know, whenever you do have a policy that is priced at UNC or RNC, they'll put it to a company such as Viant or Multiplan. They'll reprice that claim. And what I found in my experience is that they will reprice the claim according to their own NPR policy. So 125.10 is what I found that Viant is doing, although someone like United Healthcare may have 150.50. So that is a way to retrieve additional revenue by knowing these things. And you can do this by tracking the trends and just asking the correct questions. So once that information is obtained and the patient portion is figured out, you would estimate what the insurance will be paying. The questions that your verifier needs to ask is, do these combined amounts, do they meet or exceed the cost to perform the case at your facility? Next slide. Okay, so to speak more on that, back to once you confirm the methodology that is used and you decide that this case is acceptable, you will make money on this case, you're going to contact the patient and let them know what they owe. And my suggestion is to always do that in advance. You don't want to call the patient the day of or the day before surgery, which is why I say once you receive that information from the surgeon, call and verify those benefits within 24 hours. And then as soon as you've gathered all the information that you need, contact that patient and let them know what they owe. A lot of patients will be hesitant, especially in the beginning of the year. There's higher deductibles, so they may not have the money to pay that all up front. So that's why I say having payment options, doing in-house payment plans, or using companies such as credit, it will increase your revenue because you're giving options. They're able to pay that out. They're able to obtain a loan or a line of credit to pay you. So you're going to get less cancellations due to money if you allow there to be options. So once you've got that information and they're set, the next step, you're going to have the collector, and they're going to start contacting the insurance companies. Best practice, I believe, is to contact the insurance company within 10 days to make sure that that claim has been received. That is a good point to make sure that it's been received. You're going to ensure that your money is received in a more timely manner because you've been able to, ensure that it's there. Collectors, I feel, are maybe the most important part of the revenue cycle, and the reason why is because there are so many things that they can do to get even more revenue. So on this slide, I'm just stating that what the collector's responsibilities are is to gather all information on the phone call, get a start on the reconsideration process, negotiate, use carrier forms when required, know carrier timelines for disputes and posting collections, the standard collector process that you have within your facility. They need to make sure to follow that to the T. follow up timely on appeals and reconsiderations, never accept the first negotiation offer, ask questions, review previous data to confirm the allowable is being sufficient. So whenever I say negotiate and gather all information, when a collector calls to check on a claim that is for an out-of-network provider, there are certain questions that they need to ask. Those questions being, the allowable. How is that allowable determined? Is it according to the benefits that were quoted up front? If it's not, then that's when you need to start the reconsideration process. You don't want to wait until the poster gets the payment and then they're made aware of the low allowable. So they need to gather all that information on the phone call with the customer service rep at the insurance carrier. So you will ask the question, what was the methodology used for this? Do you have the right? Was it usual and customary? Are you able to negotiate that? There are times that we are misquoted, and that, again, can turn into an appeal later. But that phone call is important to obtain all the information and to get a head start. If you are able to negotiate, then there are some carriers that will contact the third-party company for you, or you have to reach out to them on your own. And when you reach out to them and you receive that negotiation, never, ever accept the first negotiation offer. You always want to ask questions in how that repricing company is coming up with their allowable. You want to ask them what their MPR is. You can even ask for an itemization of how they came up with their allowables, which is how, in my previous experience that I found out that they were doing it, 100% for the first and then 25 and 10, so on, which is unacceptable. So you always want to really just argue and negotiate with the negotiation or the negotiator. That's the whole reason for the process. There are a lot of people, a lot of facilities that I've seen in my time with MediGain that we've had to re-educate because they will accept the first offer thinking that it's the best that they're going to get, and that's not the case. Just remember that you're out of network, so not always do you have to take what they state is the allowable. Now, if you were quoted that information up front, then you knew that up front, so therefore you should have made an informed decision prior to doing that case. Next slide.
Liz, well, just a second, as you're talking about the negotiation and so forth, what kind of a case pops up at the top of your mind? The situation where you've gone through the process and you've done the negotiation and they said no, and you've kind of re-talked to them. I mean, any kind of procedures in particular?
It's across the board. I mean, I do it with all, but I know that orthopedic cases are notorious for lowballing. What I call it. Negotiators will come in and say, it was just a scope, or it was just this, because they only see what the CPT code is providing them. So there are times that I've had to dispute with the time that was given, the complexity of the cases. So orthopedic cases are notorious, and also pain. But I see where they try to send you a low allowable and argue the fact that, no, this is all that happens. So on the negotiations, you're also able to appeal with pertinent information showing the reason that you billed so high, or the reason that you feel that your allowable should be more.
Okay, thank you.
Okay, and another responsibility for the collector is to be educated and to know how to read an EOB. And I know that that's something we say, oh, I know how to do that, and it's black and white, it's easy. But if you look at this EOB, this is the United Healthcare EOB. If you look at the CPT codes and you look at the billed amount, most people, and this is for payment posting and collectors. It's necessary. Everybody needs to know how to read this. The person just kind of glancing at it would look at the allowed amount column and say, okay, well, they allowed $12,677. We're good. But really, when it comes down to it, if you look at the group RC amount and you see that $1,682.65, that's really the amount. If you take that amount and minus the billed amount, that is your allowable. I don't know why they read this way, but I've had several people to where they feel that $12,000 is sufficient as an allowable for the billed charges of $23,750, so they don't do any additional work on it. But like I said, in reality, you need that billed amount and that group RC amount. When you take the difference of that, that is your allowable. So what that tells me is, okay, we've got all this money outstanding, but I need to dispute that allowable really isn't that high. And I don't want to say that this is done intentionally, but on EOBs that you're contracted, it seems to show the correct allowable there, the correct, the correct adjustment amount. So just watch for that. I think that that's just good information to have, and just to always be aware. Do the math, give it a double look, a second or third look, just to make sure that the allowable is correct. Look at the benefits that were quoted and make sure that that payment matches the benefits that were quoted. Is that the deductible? I mean, is that the correct deductible that was quoted? The coinsurance, is that 40% or is that 60%? There are always errors in the processing of claims, so we just have to be informed and pay attention to detail in order to catch that, because that's what they're counting on. They're counting on you not to be taking a second look and not to doubt what they're doing, so that you're not going for that additional revenue. Next slide. Okay, so on the payment poster responsibilities, it's along with the collector, I believe that everybody needs to know how to review the EOB, know how to read it. They need to review the payment in detail, and also review the collector's notes. If you're out of network and there's not set guidelines that limit the reimbursement for out-of-network providers on the patient's policies, are you capturing additional revenue? Is anyone reviewing this information? Do you have a policy that is set in place for your facility? And if so, who's authorized to make the adjustments? And what has to happen prior to them being performed? I say these things because there are several centers that I've encountered to where the poster is authorized to make the adjustments, but they're not reviewing the pertinent information. There are no policies that have been put in place that give them specific guidelines to go by. So when you have that, depending on the staff that you have, there are people that just don't want to see it again. So they said, okay, well, we were paid. That looks like a sufficient amount, so I'm going to adjust that off. And that's why I say that it's important to have those policies and procedures in place, set guidelines, and somebody else needs to be taking a look at that if you're not real sure about the payment poster's experience in that. But the collector's notes need to be detailed to where that payment poster can make that decision. I am the person who looks at everything. If they did not allow 100% and there was no methodology that was given to tell me that it was going to be paid another way, then it needs to be appealed. It needs to go back to the collector, and they need to find out exactly why it was paid this way, if they had not already, and get additional money. We need to do everything that we can to get that additional money, exhaust all avenues. Next slide.
Well, Liz, and somebody just sent in a question. How, I guess this might be your part of the industry, and maybe some of the people there from Becker's ASC Review can speak to it on more, but how much, when you've come in and started working with people, how much were they kind of leaving on the table? 5%, 10%, 20%?
Much higher
Really?
for out-of-network. I would say, depending on the specialty of the center, up to 20 to 30% of money being left on the table. I know we had done a project, and that's where I talk about on this, trend tracking is what I call it. But we did a project at the ASC that I was employed at for United Healthcare and Aetna, specifically, to where we tracked information such as the patient's account number, the carrier, their group number. It was just a simple spreadsheet, had their group number, the employer's name, the methodology that was given to us at the time that we verified benefits, and then the poster and the collector were responsible then to put what we were paid. Was it based on the methodology that was given to us at the front end? And at that point, what did we do? Did we negotiate it? Did we appeal? And if we did win that appeal, what was our additional reimbursement? We collected $1.8 million additional revenue in that year. And that was a project that I was personally part of. So from United Healthcare and Aetna, in addition to what we had already received, just by doing that. And by tracking those trends or tracking those groups, we were able to make informed decisions as well as far as, you know what, we know that AT&T isn't going to pay very well for out-of-network, so you know what, that was probably one that needs to go to the hospital. We would let the surgeon know. By tracking the information, it allows us to make informed decisions. So yes, there's a lot of money left on the table, and that is a way to prevent that.
And let's have somebody weigh in from the Becker side there, since y'all do the Becker ASC review. Somebody did ask about any kind of accounts receivable benchmark data there in the industry for out-of-network centers, AR aging and or AR days. Has there been any data collected on that? Carrie, Megan?
As far as I know, we don't have anything on our end.
Okay. So I guess, Liz, out of your experience for days in AR, I guess that's kind of a broad statement and a broad category, because especially when you're going out of network. But what would you say, just some good ballparks for a well-run ASC? What are they kind of looking at for AR data? Aging, how many days out there?
I think anything over 45 is just unacceptable, even out of network. Because if you have set policies and procedures and you're checking on that claim and doing the steps that you need to take in the time frames, there's no reason that it should take more than 45 days for you to at least receive some type of notice from the carrier, or at least a first payment. 60 days, I would say, would be the max, but I have seen that there are ARs out there over 120 because of lack of follow-up. And that's something that I try to help the ASCs that we do have here at MediGain understand, that, you know, these are our policies and procedures, this is how we do it, this is why. And then the ones that I do consulting for, I also let them know, you know, you need to have set policies and procedures, guidelines on time frames, because the longer that it sits out there, it's just money that you're sitting on. I mean, you're losing money.
Well, and somebody asked the follow-up. I mean, it's already a tenuous relationship as it is with the insurance providers. So, I mean, this one person said they're already getting so much flack that they get from insurers when they're doing follow-up claims and follow-up calls. Does that hurt the relationship with the insurers, or is it kind of goes with the job? They know that they're going to throw out a price, and if you're doing your job, you know that you're going to be discussing it with them.
And you're talking about the carriers?
Yes.
They're referring to the carriers? Our job as a collector is to be persistent. We do whatever it takes to get that money. And as long as we can justify the reason that we are billing for this, whether they agree with what we billed or not, if I'm understanding this question correctly, whether they agree with the amount that we billed or not, as long as we're able to justify that, we need to be persistent in arguing that fact. So I honestly don't think that it's important to have a great relationship with the insurance carrier as long as you can justify what you're billing. And if the patient pays for their policy, those benefits are available to them. So a lot of companies want to, I guess, be ugly because you are out of network and they want to treat you differently. But that patient pays for those benefits. So therefore, we have a right to be paid, and if we can justify our charge amount and what was done, then we need to be paid. So the answer to that question is you need to do what it takes to get your money. And your relationship is not with that insurance carrier, it's with that patient. So you provided a service to that patient, the patient pays for those benefits, and therefore they need to pay you according to those benefits.
So somebody asked, you know, how can you argue with a company like Viant when they are doing the pricing for UHC? You know, and I guess it's back to that 150/50, 125/10. So is there kind of a...
It's funny that you asked that, because one of the last projects I worked on when I was actually in the ASC was starting that. The whole, you know, they said, well, I would ask for an itemization. You ask them for an itemization because you want to know what they're allowing for each code if you have multiple codes. Once you get that information, and you see that it's 125.10, once you get that information, what I was doing is going back to United Healthcare. I was going back to them and stating, this is your NPR policy, this is your policy. Why isn't Viant following that? When I spoke to Viant, they said, well, United Healthcare told us to price it this way. So what I was in the middle of is really just a he said, she said. I didn't get anywhere with that, and I was working on that. So as far as disputing, that is where tracking will come into play and will help you, because you can go back and say, well, I've got the same group, or I've got the same procedure. We're in the same area, because what they say is they go by the local area, the average for the billed amounts. Say I'm in this, you can argue with those things. The fact that you've tracked the information, you've been paid on that procedure before, it was a much higher allowable, you're in the same area, and there's no reason that it should have decreased that amount, that much. Really, I just think that keeping track of the information, the previous information, the previous payment information, and being able to access that and prove it, that's really your best defense. Like I said, I was in the middle of that project whenever I left, and even to the point to where I had an outside company that works on appeals. ASCs can, I don't want to say their name, but you can send information to them if you don't feel like that you're getting anywhere, or you've exhausted all avenues. Even they couldn't help me any further. We were starting to get their attorneys involved just to look at the verbiage between United Healthcare and Viant. So that is going to be a challenge. And as I learn more, I can let you know. You'll have our email address, and as I learn more, I can definitely put that information out to everyone on the call. I'm sorry that I don't have a better answer for that.
No problem. I mean, it kind of sounds like lawyers dealing with the judge trying to negotiate what jail time is going to be for their defendant. I mean, I guess it goes back to the skills of the being able to negotiate with them. I think somebody once said that negotiation is the ability to step on somebody's shoes without disturbing the shine. So I guess it all depends on how you deal with them. Being persistent is better than being a pain, and so they really. Do they red flag you or anything like that if you're constantly coming up? Or, like I said, it's kind of par for the course. Just like when you're in football, you expect to run into the person across the line from you, but you shake hands at the end of the game, right?
Exactly. It's expected. We're out of network. That's why it's sent to a negotiation company. So they expect it from us. And like I said before, as long as you can justify what you're doing, and prove the reason for your charges and why you feel that there should be a higher allowable, you're not going to hinder. I mean, the relationship is not going to be bad. And again, too, I think we all know that it just depends on who you get on the other line, on the other side of that line, who you get and what type of day that they're having. Because there's sometimes they'll be in agreement with you, and there's sometimes that they won't. So as long as we've got proof to back it up and data to prove what we're saying, then you should be a little more successful in your negotiations. But then again, you're going to get a stubborn one every once in a while. They're just not going to refuse. So another thing I used to ask for, and it probably doesn't seem important, but I just wanted there to be proof. If you're telling me that this is your max allowable, I need you to tell me why it's your max allowable. Is it due to the payer's provisions? Is it due to the contract, the employer? I want that information. And then whenever I would sign it and send it back, that information that they gave me, I would just write it on the negotiation and put max allowable and fax it back. So I had proof that that's what they told me. So if I find out later that that's not it, then that's the information I was given. And so maybe that's another way for me to go back and appeal. It kind of gave me a loophole. And I've had that happen before. We've actually had to get the employer involved in some situations. So the next slide. Okay. So these are really, just the points. Is your business office setting you up for failure or success? And that goes back to what we were saying. Everything, your revenue is affected by your business office and the knowledge that your business office staff has. Communication is key. Having resources available for them is key. Knowing what the case costs to perform at the ASC, they need to know this information. They need to know it to make an informed decision on whether or not you should do the case. Your biller, are they aware? Are they getting the information that they need to bill out all the charges? Is your clinical staff providing them with the implant information? As we all know, there's a lot of money to be made on implants out of network. I know that there's some people that say, well, they don't cover it, so I shouldn't bill it. No, you always bill it. You need to be consistent in everything that you do. So you bill that implant, and if you feel that it should be paid and it's not, you can prove that it is not inclusive, then appeal for that additional reimbursement. Now, of course, there's carriers like Medicare that you're not going to see that for some of those, but I do think that it's important to be consistent in your billing. Even if you know that a carrier is not going to cover it, bill it. You know, that it's important. Just be consistent in everything that you do. Also, be consistent in your claims filing. You want to make sure that the doctors are getting everything done within 24 to 48 hours, and the claims are going out in that same time frame. By doing this, your money is going to come in faster and smoother. If you've got gaps in billing, then you're going to have gaps in revenue. Checks and balances on simple items such as demographics, it can save time on the back end. So again, just your business office staff knowing the importance of each of these things and making sure that all the demographics are correct. It's going to save time for that collector to go back and try and figure out why that claim never got where it needed to go. Sometimes just a digit being off can make your revenue, it can make that money not come in for an additional 30 days. So just remember to educate your business office staff, give them the resources that they need, and explain to them the importance. Make them a part of the process. Don't, you know, as an administrator, I understand that you're busy. There are things that are going on, and you don't feel like you need to inform your business office staff. But if you make them feel like a part of the whole process, they're going to feel more like they own part of that center. They're going to be, I guess, loyal. They're going to be more loyal to the cause, and they're going to do everything that they can to make sure that that center is profitable. Next slide. Okay. So now I can speak freely, which I'm more comfortable at doing. But if you, the trend tracking that you do, a lot of collectors aren't self-motivated. So if you provide some type of easy spreadsheet that just has, like what I talked about earlier, just the group name and the group number, how much were we reimbursed, what were we told we were going to be reimbursed, and then they're able to track and see their success and say, oh, okay, well, I appealed this and I got an extra $4,000 and I got an extra $5,000. I think that is great for them to see that and to see that their hard work is paying off. It's especially great for those who aren't self-motivated. You know, we're not always lucky to get the person who we hire and they come in and they just understand the whole process and self-motivated and can't wait to bring in the money. So I think that this is a good way to drive them. And it's also a good way for the administrator to monitor what's being done and see that the efforts are paying off, the additional work that goes into out-of-network.
Okay. Thanks, Liz. We do have some questions here.
Oh, good. I like questions. I can't read from these screens. I love, ask me questions and I will answer them.
Thank you, Liz and Clint, for a very informative and enjoyable presentation. As you said, we will now begin the Q&A portion of the program. As a reminder to our listeners, you can submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Our presenters will attempt to answer as many questions as they can during the time we have for Q&A, and we will follow up on questions they do not have the opportunity to address. Clint, I will now turn the floor over to you to moderate today's Q&A.
Well, thank you very much. Here's one. If a payer is out of network, are they legally bound to write off what they deem, what is deemed as unallowable? If they charge $500 per procedure, but the insurance carrier states only $200 is allowable, do they need to write off the $300? So there's that question.
No, you are not obligated. You're not contracted with them, and the allowable is just what they state the allowable is. In fact, if you look at most EOBs, it'll show that that unallowed portion is the patient's responsibility. So they're not asking you to adjust it off, but they are asking you to bill the patient.
So would that be part of the pre-authorization and pre-verification that they would be able to find that out so that at the very beginning they could set the expectations with the patient, saying, okay, so the whole thing's $500, your insurance is going to cover $200, your part's going to be $300. How do you want to handle that? Do you want to pay with a credit card or a check or something like that, right?
Yes, you can get that information, and I did talk about that. That is something that is important to get. You always want to ask the customer service representative what the methodology is for out-of-network reimbursement. There are times that you can even give, if it's a usual and customary, you can even ask what percentile. There are some carriers that you can give a CPT code and they'll give you an estimate. So that will help you whenever you're speaking to the patient. And the more information you have for that patient up front, the better. The more informed they are, the less complaints you get on the back end. So yes, and every center does it differently. So you may already have things worked out to how you figure the patient's portion, but the EOB does, you're out of network. It basically just states what they feel is allowed, but the remaining is to go to the patient. So you're not obligated to write any of that off.
Okay, here's an interesting one. Can the ERISA, which is the Employment and Retirement Income Security Act, can that be used to, I guess, negotiate with commercial carriers if their payments are too low?
Only on plans that are governed by ERISA. And that is information that you can also get in the VOB process. Or even then, sometimes it's harder and you have to actually ask for the patient's policy, which, as we all know, that's a little bit harder than it sounds. You can go to the employer or you can ask the patient to bring up a copy. But it's only, you can only use that for plans that are governed by ERISA.
Well, that's good that you mentioned the employer, because someone was saying, how do you diplomatically and effectively approach the employer to, overturn a denial or an underpayment?
Okay. So with that, I don't think there's any reason not to be diplomatic. They're normally helpful whenever you actually do get a hold of someone within that department. The best thing to do is first just to let them know the situation. Let them know that you're working on behalf of the patient. You're trying to make this as painless as possible for the patient. And that really all you need from them is just a copy of their policy so that you can get the information that you need. If for some reason it's not in there, then you can go back to them. But really the first step is pretty easy because you're just going to request that information. If they don't want to give it, that's when I guess it could get a little less diplomatic because they are obligated, or the patient is at least obligated to get you that information. But I do find that for plans that are self-funded, it may get a little less diplomatic just because they know once your hands are on that information, you're going to know exactly what the guidelines are and that they are going to owe you additional money. So really I think every situation is going to be different, but the first thing you need to do is contact them. First you want to ask the patient to reach out to their employer. If the patient's not doing it, then just contact the employer, get your hands on that benefit booklet, and go from there. And let's just hope that you're able to get the information that you need at that point.
Well, and this is what we were talking about all these webinars being an exchange of ideas and information.
Yes.
Because somebody just said, I was under the impression that due to TPACA, all plans fall under ERISA guidelines, even fully insured policies.
I'm going to look into that. I haven't heard that, and if those guidelines have changed recently, then I need to educate myself. So thank you for that information, and I will look into it and also share that information as I retrieve it. We have all the contact information for everyone. Is that correct, Clint? To where when we send out these slides, I can give some updates? Okay.
Here we go. If billing patients for out-of-network balance, isn't there a high percentage of patients that will choose an in-network facility, which would result in lost business or revenue?
Yes, that is a risk that you take, and I can't advise on that, but I will tell you that if you have set policies and procedures in place and how you're going to collect from those patients, and you inform those patients up front, whatever your policy may be, I can't tell you how to do that. There are ways that, and marketing ways too, ways that you can sell your center to that patient and make them want to come there. But really the first step is to you need to decide within your facility what your demographic is like, the area that you're in, what's going to work best for that area, and go from there. There are some facilities that, they have hardship programs because they're in a little bit the demographic area that they're in. So they have hardship programs to where it's not going to affect them financially. There's different things that you can do. Like I said, I can't advise on exactly what your center needs to do, but there are ways to make that patient want to come to your facility and to where it doesn't affect them financially. It's not a financial burden for them.
Well, I guess it's kind of like car dealers,
I guess it's kind of like car dealers, to where if you have a good reputation, if you're considered the best in your field, you have good word of mouth, you've treated your patients well, that's kind of what kind of price do you put on health,
right,
especially when you're getting into a serious procedure, and that's where the communication with the patients and setting the expectations, because that good experience, that good overall experience starts at the very beginning with setting of the expectations.
Right. And payment options helps with that too. If you offer them a variety of payment options and you allow them to pay it out as to where someone else won't, that's going to be an incentive as well.
That's a good point. So here's one. Are providers obligated, and that's in quotes, to collect the patient out-of-pocket portion of the claim? I guess obligated is, I know it's in quotes, but it's kind of like, if you're not going to collect it, and that's kind of like the money out of your pocket, right?
Right. Well, you're not obligated to do anything because you're not contracted. But if you're talking about collecting from the patient, any portion from the patient, yes, you need to, and you need to collect up front. Again, that goes with setting guidelines, policies, and procedures in place that say, okay, this is what we do. They're out of network. Maybe we're not going to collect their deductible, but we are going to collect their out-of-network coinsurance. You do need to collect something from the patient. Now, if you're asking, am I obligated to bill the patient for everything that it states on that EOB is their portion? Some would say yes, that is the patient portion. It is an agreement between that patient and their carrier. They know that they're responsible. Now, if you have certain policies in place that are within your facility, then you just need to follow those guidelines and be consistent with whatever it is that you do as far as how you collect from those patients or the amount that you collect from those patients.
Okay. Well, somebody just contributed saying that no Medicare or federal policies fall under ERISA or church plans. Okay?
So good. So I wasn't.
So there we go.
Still might need to educate on a little bit of it, but okay. Thank you very much for that.
That's part of that's what's great about these exchange of information from people who are actually out there in the trenches.
Right. None of us are experts. None of us are experts. If we miss a day of learning something in this industry, we're behind. So there's so much that goes with it, especially at an ambulatory surgery center. So I am all about sharing information and being educated daily.
Well, here's one that's from my and my wife's personal experience. It says, if the physician and the ASC are in network, but the anesthesia provider is out of network, are we required to accept the in-network allowable for anesthesia? Good question.
Well, it depends on the patient's policy again. Does RAPS, is that something that is on the patient's policy? Now, this may be someone asking that has anesthesia that they bill for at their facility. And I'm not sure because I'm not able to ask them, but if it is to where you have an ASC and you also provide anesthesia services that you bill for, if you're asking, okay, we're out of network, the surgeon's out of network, but our anesthesia group, in network, our anesthesia group is out of network, do I have to accept that? Now, if the patient has a RAPS policy, then I would say yes. Because it says there, that it's going to be covered. If the providers are in network, we are going to pay the anesthesiologist as if they're in network. And to dispute that, I understand it from a provider perspective because we want to get the maximum reimbursement. Now, if we really are doing this and our patients are our number one, it's benefiting them for it to be covered under that in-network. So as far as appealing it, yes, you can appeal it because you're not contracted. The RAPS, and I would have to look into that, but the RAPS, I believe, will override that. And then in the end, you really just kind of look like a not a very nice person for disputing that whenever it was really a benefit for the patient. It helped the patient have, lower financial obligations.
Can a facility bill an out-of-network patient the in-network benefits, and what is the legality of that? Now, you just played a lawyer on TV, right?
Well, I have an opinion on that. I do. And what I can do is tell you examples of how some facilities do it, but I cannot advise you on whether or not you can do it. So there are facilities that I've encountered in my past that they do have a policy in place where they honor in-network benefits. And what they do is they don't collect the deductibles. They find out what the allowable methodology is for out-of-network, and they apply the in-network co-insurance to that allowable and bill the patient. So again, it's up to you, your facility, and whatever you do, be consistent in what you do and be able to back up the reason for that. So I cannot legally state, hey, this is how you should do it, but I will say that it's a very fine line, and everybody has different views. There's been Cigna lawsuits going on in California. I know that somebody won, but really look at the details of that before you get excited and think that it's okay to do things a certain way. So again, written policies, procedures, and be consistent.
Okay, so here's one. RAPS only applies to hospital-based emergency urgent care ambulance services and not office freestanding facilities, right? I guess that's the question. It's for when a patient doesn't have a choice in provider?
Well, so did the patient, I'll have to look at that and see if it just applies to certain situations, but I'm thinking also at an ambulatory surgery center, the patient is going in, they're having the procedure done, sometimes they'll meet with the anesthesiologist, I guess they do in pre-op, but do they really get a say in who's providing the service there if only out-of-network anesthesiologists are credentialed at that facility? So that is something, that is definitely a good question or a good statement, and I'll look into that. I was not aware that there were restrictions on that. It was RAPS includes those, includes that for to fall under the category of in-network whenever the hospital or the physician is.
Okay, well,
So that's good.
Yolanda was saying that
so we're all
it
learning
applies
something.
to ASCs as well.
Mm-hmm.
So as far as that anesthesia, say that you looks like that Yolanda pitching in says that you do have to accept the in-network allowable for the anesthesia and that it only applies to the ASCs. Here's one about, can you give some examples of methodologies in which department would you verify this information with? Benefits/customer service department, provider relations, claim department?
Okay, so here's my advice on the benefits. You're going to talk to, whenever you call the insurance carrier, you're going to be directed to the verification of benefits area. So you're going to talk to a representative there who specializes in verification of benefits. The methodologies, examples of that is you'll have carriers that either do 50% of billed charges. They may do a percentage of Medicare, such as 140%, which, as we all know, is an MNRP policy. And let's see, you've got some that will do 300%, or you'll have usual and customary, and they'll say it's the 75th percentile of usual and customary, the 95th percentile. Another piece of advice that I'd like to give everyone is do not ask that verification of benefits person, is pre-authorization required? You need to contact, for out-of-network, you need to be asking this for every carrier, for every patient, and you need to go through the authorization department whenever you ask that and make sure you get a reference number, because I've seen so many denials come through to where they said pre-certification wasn't obtained. Well, I asked the customer service rep, and they said that it wasn't needed. The information they're giving you is general. It's outpatient. They're not looking at whether or not you're out-of-network or in-network. When you call the authorization department, you are going to talk to someone who is looking at your tax ID or your MPI, and they are able to give you accurate information. So I just want to put that out there to go with that. So you're going to ask for the benefits department, and normally there is an automated button that you can press, and it'll direct you right to them.
Okay, I think we only have time for one more question, and then we'll be wrapping it up. It's an interesting philosophical question. It's how do in-network physicians minimize their downside for referring to an out-of-network ASC?
That's good. So I'm guessing that they're asking, I know the in-network providers catch a lot of slack from carriers. They get a lot of threatening letters for being affiliated with an out-of-network surgery center. In my experience, they threaten the providers, but really they can take away, you may have a status with Aetna that makes you a little bit higher of a provider, and I can't think of the name right now, but makes you some type of elite provider. So you're getting more referrals. So they can, not necessarily will they take their contract away, but they will take that status from you so that it's going to affect your business and get you shook up a little bit. But I've never actually seen a carrier terminate a contract because they utilize an out-of-network facility. They do discourage, and they do send several threatening letters. The ASCs that I worked in had carriers that were contracted, and we were non-par. So I did see a lot of threats, but I never saw them carried through. My advice to you is just to, you're going to do cases everywhere, but just if that's the only place you're credentialed, then unfortunately that's the only place you're credentialed. You're just going to need to provide backup on why you do the surgeries there.
Well, evidently, and this is a good thing that we have people from all across the country. It's saying several people have chimed in on that, saying that in Jersey they've got dozens of providers, and another one says they terminated his contract. They did it to us. They did terminate one of our doctors' contracts. So I guess that's the downside of in-network physician referring to an out-of-network ASC. I mean, it does look like they'll drop providers, and I guess that's if you do it all the time. I mean, if you do it occasionally, that's a side. People, this is the experience from other people out there. Is I guess it's your conscience, your neighborhood, and your pocketbook will all do into that, and you're looking at patient care also as far as you refer. But just know, evidently, that some providers have canceled contracts for out-of-network providers, and that about does us with time for today. I'll turn it back over to our Vickers ASC people for the wrap-up of today's webinar.
Absolutely. I want to again thank our presenters for their excellent presentation and all of you for participating today. We look forward to having you join us for future webinars. This concludes today's program. Have a wonderful afternoon.